Good morning, my dear students. Today we will talk about the clinical anatomy of the neck. The neck is the part of the body that distinguishes the head from the torso or trunk. Many vital structures pass through this area of the body. The skeleton of the neck is formed by the cervical vertebra, hyoid bone, usually referred to as the hyoid, manubrium of the sternum, and clavicles. The mobile hyoid lies in the anterior part of the neck at the level of the third cervical vertebra, in the angle between the mandible and thyroid cartilage. The hyoid does not articulate with any other bone and functionally serves as an attachment for the anterior neck muscles and a probe to keep the airway open. The triangles of the neck are the topographic areas of the neck bounded by the neck muscles. The sternocleidomastoid muscle divides the neck into the two major neck triangles, the anterior triangle and the posterior triangle of the neck, each of them containing a few subdivisions. The triangles of the neck are important because of their contents, as they house all the neck structures, including glands, nerves, vessels, and lymph nodes. The sternocleidomastoid muscle divides the neck into two anatomical triangles. These are often referred to in clinical practice and in exams when describing lumps in the neck, and therefore an understanding of them is essential. It should be recognized that these triangles are artificial and have not been chosen for clinical or embryological reasons, and as a result, pathology doesn't often respect or follow their boundaries. On this picture, on this table, you can see the peculiarities of the triangles of the neck. The median line of the neck divides the neck into symmetrical halves. The sternocleidomastoid muscle in its oblique, posterior-superior course further divides the neck into anterior and posterior triangles. The anterior triangle of the neck is further subdivided into four smaller triangles, while the posterior triangle is broken up into two smaller triangles. The anterior triangle is the triangular area of the neck found anteriorly to the sternocleidomastoid muscle. It is formed by the anterior border of the sternocleidomastoid laterally, the median line of the neck medially, and by the inferior border of the mandible superiorly. The apex of the anterior triangle extends towards the manubrium sterni. Now you can see the anterior triangle of the neck, in Latin trigonum cervicale anterius. It is colored in green. The anterior triangle is further subdivided into the muscular or omotracheal infrahyoid triangle, carotid triangle, submandibular triangle, and submental triangle. Thus, you can see borders, subdivisions, and contents of the anterior triangle. The muscular or omotracheal triangle also shares one margin with the anterior triangle, the median line of the neck. However, the muscular triangle begins at the inferior border of the body of the hyoid bone. It has two posterior borders, the proximal part of the anterior border of sternocleidomastoid inferiorly and the anterior part of the superior belly of the omohyoid superiorly. Here you can see the borders or boundaries and contents of the muscular triangle. The carotid triangle, similar to the muscular triangle, has the omohyoid and sternocleidomastoid muscles as parts of its borders. However, it is the posterior margin of the superior omohyoid muscle that limits the triangle anteriorly, and the anterior margin of the sternocleidomastoid posteriorly. On this picture, you can see the carotid triangle. It is lined by a blue pencil. The peculiarities of the carotid triangle, its borders and contents. Borders or boundaries. The posterior border, which is the largest of these sides, or the base of the triangle, is formed by the sternocleidomastoid muscle. Anteriorly, shortest side is composed of the omohyoid muscle, and the anterosuperior border is limited by the posterior belly of the digastric muscle. Here you can see the posterior belly of the digastric muscle, lateral right view. It is colored in green. The hyoid bone can be seen in the most anterior angle of the carotid triangle, with two of the three sides either originating or inserting upon it. Medially, the floor of the triangle is formed by parts of the thyroid muscle, the hyoglossus muscle, and the middle and inferior pharyngeal constrictor muscles. It is covered laterally by the integument, the platysma, and the superficial and deep cervical fascias. Contents of the carotid triangle. As previously stated, the contents of the carotid triangle are made up of arteries, veins, and nerves. As about arteries, of the arteries in the triangle, the common carotid artery is the largest, where it bifurcates in the upper corner of the triangle into the internal and external carotid arteries. Other arterial branches visible in this space are branches of the external carotid artery. They are the superior thyroid artery, the lingual artery, the facial artery, the occipital artery, the ascending pharyngeal artery. On this picture you can see common carotid artery. Now you can see external carotid artery and its branches. On this picture you can see the arterial system of the neck, including common carotid artery, external carotid artery with its branches, and the cut of the internal carotid artery. As about veins, all they correspond to a previously mentioned artery, where they all drain into the internal jugular vein. The later runs laterally to the common carotid artery. The list of veins includes the superior thyroid vein, the lingual veins, the common facial vein, the occipital vein, and the ascending pharyngeal vein. Here, the internal jugular vein is demonstrated. Nerves. When relating to the nerves, an important structure must first be mentioned before the other descending cranial nerves, the carotid sheath. It is formed by the middle cervical fascia, where it encompassed the vagus nerve. This is the 10th cranial nerve, as you know, as well as the internal jugular vein, the common carotid artery, and deep cervical lymph nodes. Superficial to the carotid sheath, the hypoglossal nerve. This is the 12th cranial nerve. Also descends within the triangle, as does the accessory nerve, the 11th cranial nerve, and the ansa cervicalis profunda. Nerves of the carotid triangle. Vagus nerve and its way and its branches. Sympathetic trunk. The part of the sympathetic nervous system. The carotid sheath is one of 4 accumulations of deep cervical fascia, or fibrous connective tissue of the neck, which surrounds the great vessels of the neck. It extends from the base of the skull caudally to the first rib on the sternum. More precisely, it starts bilaterally at the level of the oropharynx on the lateral side of the retropharyngeal space, beneath the sternocleidomastoid muscle. The carotid sheath surrounds the following anatomical structures: the common carotid artery, the internal carotid artery, the internal jugular vein, and the vagus nerve. Internal jugular vein laterally, common carotid artery in the lower part, and internal carotid artery in the upper part. Medially, vagus nerve in the posterior plane. And relations: anteriorly ansa cervicalis, posteriorly sympathetic trunk. The relation of the structures of the carotid sheath. Clinical aspects. Pathological conditions that directly affect the carotid sheath are rare, and it's much more common to see disorders that affect the contents of the sheath. Vascular disorders, neurological disorders, and lymphatic diseases would affect the sheath and the rest of the contents secondarily. One scenario, however, that does involve the sheath is that on extensive dental infection. The spreading of untreated dental fucus can lead to cellulitis within the space of the head and neck. Should the fascia of the carotid sheath become involved, the infection could easily spread to the mediastinum and cause mediastinitis or even endocarditis. The carotid triangle provides an important surgical approach to the carotid system of arteries. The internal jugular vein, the vagus and hypoglossal nerves, and the cervical sympathetic trunk. Damage of or compression of the vagus and recurrent laryngeal nerves during surgical dissection of the triangle may produce an alteration in the voice because these nerves supply laryngeal muscles. Like the anterior triangle, The digastric or submandibular triangle is limited superiorly by the same structures. Its inferior boundaries are formed by the posterior bailey of the digastric and stylohyoid muscles posteriorly, and the anterior bailey of the digastric muscle anteriorly. The apex of this triangle rests at the intermediate tendon of the digastric muscle. Its floor is formed by the mylohyoid and hyoglossus, while it is roofed by skin, fascia, and platysma. Here you can see the submandibular or the digastric triangle. As mentioned above, the submandibular triangle is a subsection of the larger anterior triangle of the neck, which is defined by the following boundaries: lateral, the sternocleidomastoid muscle; superior, inferior border of the mandible; medial, anterior midline of the neck. On this picture you can see the structures of the submandibular triangle. Boundaries. The submandibular triangle, also known as the gastric triangle, is located superior to the hyoid bone. It is bounded superiorly by the inferior border of the mandible and the mastoid process, posteriorly by the posterior bailey of the digastric and stylohyoid muscles, and anteriorly by the anterior bailey of the gastric muscle. Contents. In terms of surgical practice, the submandibular triangle is best visualized as having 4 layers. These layers start from the skin and continue progressively deeper. First layer, or the roof. As previously mentioned, the roof of the submandibular triangle, the first plane encountered surgically, comprises of the skin and the superficial fascia. This includes the platysma muscle and the subcutaneous fat. Also enclosed are the cervical and mandibular branches of the facial nerve. Second layer, or submandibular space. If we study the second surgical plane of the submandibular triangle, the following contents can be found: the submandibular lymph nodes, the superficial portion or lobe of the submandibular gland, the submental branch of the facial vein which accompanies the submental branch of the facial artery. The vessels and nerves of the mylohyoid muscle lie directly along the inferior surface of the same muscle. The superficial or investing layer of the deep cervical fascia is also located here. Second layer, submandibular space. Both the facial vein and anterior branch of the retromandibular vein cross the triangle anterior or superficial to submandibular gland and unite near to the angle of the mandible to form the common facial vein. The common facial vein then drains into the internal jugular vein near the greater cornu of the hyoid bone. The facial artery, which is the fourth branch of the external carotid artery, also enters the submandibular triangle by passing beneath the posterior bailey of the digastric muscle, as well as the stylohyoid muscle. Once it enters the triangle, it also lies deep to the submandibular gland. Once the artery has crossed the gland over its posterior aspect, it curls around the inferior border of the mandible and ascends superomedially across the facial region. The inferior tip of the parotid gland can be found within the posterior region of the digastric triangle. Ascending within the substance of the parotid gland is the external carotid artery. Submandibular space. Third layer, or the floor. Next is the third surgical layer. Once again, the structures from superficial to deep are the mylohyoid muscle along with its nerve, the hyoglossus muscle, as well as the middle constrictor muscle, which lies over the lower part of the superior constrictor, and a subsection of the styloglossus muscle. The mylohyoid muscles are regarded as the true diaphragm or the floor of the mouth. These muscles arise from the mylohyoid line that is found on the inner surface of the mandible and inserts into the body of the hyoid bone itself. The nerve that supplies the mylohyoid is a branch of the alveolar division of the mandibular division of the trigeminal nerve and lies on the surface of the inferior aspect of the muscle. The superior surface is mylohyoid is in contact with the lingual nerve and hypoglossal nerve. Fourth layer, basement or sublingual space. Finally, we have the deepest or fourth surgical plane. The structures within this plane from superficial to deep are the deep portion of the submandibular gland, the duct of the submandibular gland or Wharton's duct, the lingual nerve, the sublingual artery and vein which lie superficial to the sublingual gland. Deep still we find cranial nerve, number 12. This is the hypoglossal nerve, as well as the submandibular ganglion. The submandibular duct is found inferior to the lingual nerve, except where the lingual nerve passes beneath it, as well as superior to the hypoglossal nerve. On this picture you can see the submandibular ganglion. Here is the pathway of the facial nerve. A major landmark of the submandibular triangle is the submandibular gland, innervated by the facial nerve. The salivary gland can be described as having two lobes, which are divided by the posterior border of the mylohyoid muscle. The superficial lobe is the larger of the two located superficial to the inferior surface of the mylohyoid muscle. The smaller deep lobe wraps around the posterior border of the mylohyoid, which will be further elaborated on below. The submental triangle is located between the anterior bases of the left and right digastric muscle. The base of the triangle is formed by the body of the hyoid bone and its apex extends towards the symphysis menti. This triangle, like the submandibular triangle, is floored by the mylohyoid muscles and roofed by the platysma, fascia, and skin. This is the scheme of the boundaries and contents of the submental triangle. This table demonstrates the borders and the contents of this triangle also. The posterior triangle is a triangle area found posteriorly to the sternocleidomastoid muscle. It has three borders: anterior, posterior, and inferior. The anterior border is the posterior margin of the sternocleidomastoid muscle. The posterior border is the anterior margin of the trapezius muscle, while the inferior border is the midline one-third of the middle one-third of the clavicle. This picture demonstrates us the posterior triangle of the neck. It is colored in green. The investing layer of deep cervical fascia is intergarment, forms the roof of the space, while the floor is covered with the prevertebral fascia along the levator scapula, splenius capitis, and the scalene muscles. The inferior belly of omohyoid subdivides the posterior triangle into a small supraclavicular and a large occipital triangle. Borders, subdivisions, and contents of the posterior triangle. Occipital triangle. The anterior and posterior margins of the occipital triangle are the same as those of the posterior triangle. However, its base, inferior border, is now formed by the superior margin of the inferior belly of the omohyoid muscle. Here you can see borders and contents of the occipital triangle. Supraclavicular or omoclavicular triangle. Finally, the supraclavicular triangle or greater supraclavicular fossa is the smaller of the two posterior triangles. It shares anterior and inferior margins with the posterior triangle. However, it is limited superiorly by the inferior border of the omohyoid. Scalenus medius, the first digitation of the serratus anterior and the first rib are in the floor of this triangle. The roof is formed from the skin, fascia, and platysma. The subdivisions of the posterior triangle are occupied by the regional lymph nodes. The third part of the subclavian artery, suprascapular and transverse cervical branches of the thoracocervical trunk, external jugular vein, trunks of the brachial plexus, and the fibers of the cervical plexus. Here you can see the way of the external jugular vein. Here you can see the topography of the lateral cervical region. The veins of the neck. Key facts about the external jugular vein. Drains from confluence of posterior division of the retromandibular vein with the posterior auricular vein. Tributaries: cervical, suprascapular, anterior jugular veins. Drains to subclavian vein. Drainage area: scalp and face. Clinical significance. The external jugular vein has significance in everyday clinical practice, namely increased pressure in the superior vena cava or the right atrium of the heart causes blood flow to back up into the internal and external jugular veins. This results in jugular venous distension, in which the jugular veins, and especially the external jugular vein, due to its superficial location, become visibly engorged. Thus, distended neck veins can be a telltale sign of conditions such as congestive heart failure, cardiac tamponade, pulmonary hypertension, or superior vena cava obstruction. Borders and contents of the supraclavicular triangle. The deep structures of the neck are the prevertebral muscles located posterior to the cervical viscera and anterolateral to the vertebral column, and structures located on the cervical side of the superior thoracic aperture, the root of the neck. Here you can see the deep structures of the neck. Now let's talk about the fascias of the neck. The neck is divided into anatomical compartments by strong fascia, which is arranged in layers and tends to align neck structures and bundles. These are real and important anatomical divisions and have great relevance clinically. Structures making up the neck are surrounded by a layer of subcutaneous tissue called the superficial cervical fascia and are compartmentalized by a second group of fascia referred to as deep cervical fascia. Here you can see the cut of the neck on the level of the sixth cervical vertebra, which is more representative. The fascia of the neck is described according to Shevkunenko, is divided into 5 layers. This classification is based on clinical significance and relationship. The first layer is described as superficial fascia containing platysma, superficial veins, and nerves. This is the Russian and Soviet anatomists and well-known scientists Shevkunenko Viktor Nikolaevich. The subcutaneous tissue of the neck, or superficial cervical fascia, is a layer of connective tissue that lies between the dermis of the skin and the investing layer of deep cervical fascia. It contains cutaneous nerves, blood and lymphatic vessels, superficial lymph nodes, and variable amounts of fat. Anterolaterally, it contains the platysma. The platysma, a muscle of facial expression, arises in subcutaneous tissue covering the superior part of the deltoid and pectoralis major muscles and sweeps superomedially over the clavicle to the inferior body of the mandible. It is a broad, thin sheet of muscle. Platysma and sternocleidomastoid. Green color demonstrates us the fibers of the platysma that arise from the inferior margin of the mandible, pass on lateral aspect of the neck, and continue to the chest to the level of the first 2 or 3 ribs. The deep cervical fascia of the neck has 4 layers, listed from superficial to deep. The first is known as the investing layer, or lamina superficialis fasciae cervicalis, or colli propria in Latin, and surrounds the sternocleidomastoid muscle and trapezius muscle. The second one, known also as the aponeurosis homoclavicularis or Richet. Richet is the author, the anatomist who described this fascia firstly. Or lamina profunda or pretrachealis fasciae colli cervicalis, or colli propria. Surrounds all the infrahyoid muscles. The outmost layer that surrounds the neck is the investing fascia. It is attached above to the mandible and skull base and below to the clavicles and cervical spine. The third is called the pretracheal fascia, or fasciae endocervicalis. The fourth cervical fascia by Shevkunenko with parietal and visceral layers and encloses the visceral region of the neck. Its parietal layer includes the carotid sheath, which encompasses the vascular region of the neck. Lastly, the fourth facial layer, the fifth one by Shevkunenko, is the prevertebral fascia, and it surrounds the vertebral region of the neck. There are 2 main compartments of the neck which are separated by the prevertebral fascia. Posterior, skeletal compartment, contains the cervical spine and its musculature. This need concern us no further. Anterior, or visceral compartment, contains all the other structures and organs. This contains bundles of structures, each of which is enclosed by a facial envelope. Between all of these facial bundles are potential spaces, known collectively as the deep neck spaces. Herein lies further clinical relevance, since disease, particularly infections of the neck, can spread along these spaces from deep-sheeted abscesses. On this picture, you can see the compartments of the neck. Now let's look through layer by layer. The first one that is colored in green on this picture is the subcutaneous tissue of the neck, or superficial cervical fascia. Look attentively. Here it is. Then platysma muscle, or musculus platysma. The superficial fascia in the structure of the subcutaneous tissue. Then sternocleidomastoid muscle. Then trapezius muscle. Then lamina profunda fasciae cervicalis, or coli propria. This is the third fascia by Shevkunenko. Sternohyoid muscle. Sternothyroid muscle. Omohyoid muscle. All these muscles are covered by the sheath formed by the third fascia according to the Shevkunenko's classification. I mean the lamina profunda fasciae coli propria. But previous group of muscles, I mean the sternocleidomastoid muscle and the trapezius muscle, are covered by the facial sheath made of second cervical fascia. This is lamina superficialis fasciae coli propria. Lamina visceralis fasciae endocervicalis. There is a peculiarity that the fourth fascia by Shevkunenko, fasciae endocervicalis, produces two layers. The first one surrounds the space that is called the cavity of the neck and forms the sheath for the main vascular-nose bundle of the neck. And the second one, the internal layer, covers the organs of the neck, and it is called lamina visceralis fasciae endocervicalis. Now you can see this layer colored in green. Then buccopharyngeal fascia, in Latin fasciae buccopharyngea, right here and here. Carotid sheath, vagina carotica. Ala fascia, fasciae alaris. Deep layer of deep cervical fascia, lamina profunda fasciae cervicalis profunda. Longus coli muscle. Scalenus anterior muscle. Scalenus medius muscle. Scalenus posterior muscle. Levator scapular muscle, musculus levator scapulae. Deep cervical muscles, musculi cervicalis profunda. This group of muscles. Multifidus muscle, musculus multifidus. Semispinalis cervicis muscle, musculus semispinalis cervicis. Semispinalis capitis muscle, musculus semispinalis capitis. Splenius cervicis muscle, musculus splenius cervicis. Splenius capitis muscle, musculus splenius capitis. Vascular compartment, compartamentum vasorum. Retropharyngeal compartment, compartamentum retropharyngeum. Danger space of Gradinsky, spatium prevertebrale interfasciale. Recurrent laryngeal nerve, nervus laryngeus recurrens. Phrenic nerve, nervus phrenicus. Then, let's talk about the lymph nodes of the neck. There are from 2 to 300 of lymph nodes in a normal person's head and neck. The largest and most frequently enlarged is the jugular digastric node. The organs of the neck. The cervical viscera, or organs of the neck, are organized in 3 layers, named for their primarily functions. Superficial to deep, they are the endocrine, thyroid and parathyroid glands, the respiratory layer, larynx and trachea, and the alimentary layer, pharynx and esophagus. The complex of organs of the neck. Thyroid gland and its location. Key facts about the thyroid gland. Functions. It secretes thyroid hormones that regulate body metabolism and calcium homeostasis. It has 2 lobes, left lobe and right lobe, isthmus and pyramidal lobe. This lobe may be absent. Histology cells, thyrocytes that synthesize thyroglobulin, from which such hormones as T3 and T4 are released. Parafollicular or C cells that secrete calcitonin. As a functional unit, we have thyroid follicle, central lumen filled with colloid, the storage of thyroglobulin, surrounded by thyrocytes and C cells. Endocrine control, increased TRH by hypothalamus, increased TCH by pituitary gland, increased synthesis of thyroid hormones, decreased TRH, negative feedback loop. Vascularization, arteries, superior and inferior thyroid arteries, veins, superior, middle and inferior thyroid veins. Innervation, cervical ganglion, sympathetic, recurrent laryngeal nerve, parasympathetic, and clinical relations, ectopia, adult thyroid disease. The thyroid gland is a butterfly-shaped vascular red-brown endocrine gland situated in the middle of the anterior neck. Under normal circumstances, it extends from the level of the fifth cervical vertebra to the first thoracic vertebra. On average, the gland weighs between 15 to 25 grams and is the largest of the endocrine glands. The main functions of the thyroid gland is the production of two hormones that take part in the many metabolic processes of the body. These hormones are called thyroxine or T4 and triiodthyronine or T3. The irregular structure is encased in the pretracheal part of the deep cervical fascia, fascia endocervicalis, or the fourth cervical fascia by Shevkunenko. Its visceral layer, It is made up of a central isthmus that connects the right and left lobes of the organ intermedially. Between the ages of 4 months to 15 years, the thyroid gland appears the same in both males and females. However, the gland is slightly heavier in females over the age of 15 than in male counterpairs of similar age. The structure of the thyroid gland. Different aspects of view. Each lobe is roughly conical in shape, with each apex pointing superlaterally and their bases inframedially between the fourth and fifth tracheal rings. At their widest point, each lobe measures about 3 cm in the transverse plane and 2 cm in the anterior-posterior dimension. The lobes are roughly 5 cm long. The isthmus lies above the second or third tracheal cartilages and measures 1.25 centimeters in both the transverse and vertical planes. In some individuals, there may be a third lobe of the thyroid gland known as the pyramidal lobe. It's also a conical structure that extends from the isthmus up to the hyoid bone. In some cases, it may also arise from the inframedial aspect of either left or right lobes, but it is more commonly seen arising from the left lobe. Related structures. The major laryngeal cartilages provide a scaffold for the thyroid gland. Posteromedially, the gland is attached by the lateral thyroid ligaments to the cricoid cartilage. Additionally, the levator glandulae thyroidae, levator of the thyroid gland, which is fibromuscular structure, also anchors the isthmus of the pyramidal lobe of the hyoid bone. Recall that the neck can be subdivided into paired anterior and posterior triangles. The anterior triangles are formed in the midline by an imaginary line called the median line of the neck that transects the symphysis menti, mandibular symphysis, laterally by the medial body of the sternocleidomastoid and superiorly by the inferior body of the mandible. The thyroid gland occupies the inferior part of the both anterior triangles. There are several neck muscles that course over the anterior surface of the thyroid gland. The sternothyroid forms the intermediate anterior relation, and more anteriorly lie the superior belly of the omohyoid muscles and sternohyoideus, while fibers of the anterior body of sternocleidomastoid course over the anterior-inferior region of the gland. The sternohyoid muscle also wraps around the lateral convexity of the gland as well, thus limiting the superior poles of the thyroid gland from projecting on the thyrohyoid muscle. The superior poles of the gland also come into close proximity with the inferior pharyngeal constrictors. Additionally, it is separated from the lamina of the thyroid cartilage as well as the cricoid cartilage by the posterior part of the cricothyroid muscle. Medially, the gland is related with larynx and trachea and is fixed to the cricoid cartilage along with the first two tracheal rings by the suspensory ligament of Berry. The cricothyroid muscles and the inferior constrictors of the pharynx are the medial muscular relations. The external laryngeal nerve passes by the gland along the body as well. Both the recurrent laryngeal nerve and the trachea are posterior inferiorly related to the medial body of the thyroid gland. The external laryngeal nerve passes by the gland along this body as well. Both the recurrent laryngeal nerve and trachea are posterior inferiorly related to the medial body of the thyroid gland. Here you can see the inferior thyroid artery that arises from the thyrocervical trunk. This is the branch of the arteria subclavia. Superior thyroid artery, the branch of the external carotid artery, usually the first branch of this artery. Parathyroid glands. The relation of the thyroid and parathyroid glands. During a thyroidectomy, excision of the malignant thyroid gland, the parathyroid glands are in danger to being inadvertently damaged or removed. These glands are safe during subtotal thyroidectomy because the most posterior part of the thyroid gland usually is preserved. Variability in this position of the parathyroid glands, especially to the inferior ones, puts them in danger of being removed during surgery on the thyroid gland. If the parathyroid glands are inadvertently removed during surgery, the patient suffers from tetany, a severe convulsive disorder. The generalized convulsive muscle spasms result from a fall in blood calcium levels. Hormone replacement therapy is required. The overview of the larynx. The larynx is a complex hollow structure located in the anterior midline region of the neck. It is anterior to the esophagus and at the level of the third to the sixth cervical vertebra in its normal position. It consists of a cartilaginous skeleton connected by membranes, ligaments, and associated muscles that suspend it from surrounding structures, and sits just above the trachea and it continues with the oropharynx, the portion of the throat posterior to the oral cavity above. The larynx conducts air into the lower respiratory tract and closes off the airway, especially during swallowing, to prevent aspiration of food. It's commonly referred to as the voice box or the organ of phonation, as it houses the structure responsible for sound production. It is quite mobile in the neck and can be seen and felt moving upward and forward during swallowing, closing off the trachea and opening the esophagus. The larynx is composed of these large unpaired cartilages, cricoid, thyroid, and epiglottis, and three paired smaller cartilages, arytenoid, corniculate, and cuneiform, making a total of 9 individual cartilages. The thyroid cartilage is the largest of the laryngeal cartilages and is composed of hyaline cartilage. It forms the anterior and lateral portions of the larynx and has no posterior component. Key facts about the larynx. Please look through and remember it. Thyroid cartilage. Also, the thyroid cartilage, its posterior aspect. Then, my dear students, let's talk about glomus tumors or hemodectomas. A paraganglion is a group of non-neuronal cells derived of the neural crest. They are named for being generally in close proximity to the sympathetic ganglia. They are essentially of two types. First one, chromaffine or sympathetic paraganglia made of chromaffin cells, and second group, non-chromaffin or parasympathetic ganglia made of glomus cells. They are neuroendocrine cells, the former with primary endocrine functions and the later with the primary chemoreceptor functions. Tumors of the paraganglionic tissues are known as paragangliomas, though this term tends to imply the non-chromaffin type and can occur at a number of sites throughout the body. Chromaffin paragangliomas are used from chromaffin cells and are known as pheochromocytomas. Adrenal pheochromocytomas are usually benign, while extraadrenal ones are more malignant. Non-chromaffin paragangliomas are issued from glomus cells, also known as glomus tumors. They are usually benign, but press adjacent structures because of their growth. They are generally present at the head and neck, more often at carotid body of jugular tympanic. Glomus tumors of the head and neck paraganglia are part of the extraadrenal neuroendocrine system. And glomus tumors of the head and neck are associated with 4 primary locations as follows. Look at this picture and remember those 4 primary locations. First one, jugular bulb. The tumors here are commonly called glomus jugulare tumors. These arise in the adventitia of the dome of the jugular bulb. This is the most common type of glomus tumor of the head and neck. Then, second one, middle ear cavity. Tumors here are commonly called glomus tympanicum tumors. They arise from the glomus bodies that run with the tympanic branch of the glossopharyngeal nerve. Glomus tympanicum tumors are the most common primary neoplasms of the middle ear. Third group, vagus nerve. Tumors in this area are commonly called glomus vagale tumors because of their usual close association with the vagus nerve, especially they arise infratemporally along the course of the cervical vagus nerve. Carotid body tumors. Carotid body glomus tumors, also called carotid body tumors, occur at the bifurcation of the common carotid artery and arise from the tissue of the normal carotid body. Carotid body tumors are rare neoplasms, although they represent above 65% of head and neck paragangliomas. These tumors develop within the adventitia of the medial aspect of the carotid bifurcation. The carotid body is a chemoreceptor located in the adventitia of the bifurcation of the common carotid artery. Carotid body monitors the blood pH, the concentration of carbon dioxide and oxygen, and thereby modulates the cardiovascular and respiratory function primarily through sympathetic tone. Carotid body tumors resection. Surgical approach, optional incisions. Perform wide exposure through horizontal incisions in a relaxed skin tension line, extending up to mastoid tip. Long incision along anterior body of the sternocleidomastoid muscle. Carotid endarterectomy approach could be used for small tumors also. Identifying and reflects the sternocleidomastoid and the jugular vein posteriorly to allow visualization of the tumor and adjacent cranial nerves. expose and isolate the proximal 3 or 4 centimeters and distal 2 centimeters portions of the vessels. I mean common carotid, internal carotid, and multiple branches of the external carotid. If vessel loops are retained around the common or internal carotid arteries, care must be taken to avoid unnecessary tension. Identifying and preserve cranial nerves, 10th, 11th, and 12th, superior laryngeal nerve and sympathetic trunk. Begin slow and careful dissection using bipolar cautery with gentle, blunt, and sharp dissection of the tumor of the internal carotid and carotid bifurcation using loop or microscopic magnification. Irrigating bipolar forceps or manual cell line irrigation during bipolar activation may be useful. Generally, the external carotid artery requires the resection at or near the carotid bifurcation. The neck is the seat of some very peculiar cystic tumors and fistula which are connected with developmental defects. They are either lateral or median in location. The lateral originate from the visceral or branchial clefts, while the medial are connected with the thyroglossal duct. The visceral clefts are depressions between the visceral arches. These arches, 5 in number, spring forward from each side of the embryo to form the neck region. Sometimes these arches are called branchial arches from the fact of they are going to form the branchia or gills of fishes and some of the other lower orders of animals. Here you can see the fetus 25th day, showing branchial or visceral arches and clefts of furrows, grooves, and porches. Early development of the pharyngeal grooves and porches. First part, the left part of the picture demonstrates early development, and the right part of the picture demonstrates later development. Observe the second arch overgrowing the second, third, and fourth grooves, leaving the cervical cyst in drawing B, of course. Note the diverticula of porches 3 and 4 as each develops, dorsal and ventral prolongations. Cervical cyst and fistula. Lateral cyst can be detected immediately after birth. Median cysts are less noticeable and are found by chance in the course of the survey or many years later after the child grows up. Treatment of the neck cyst requires surgery. Lateral neck cysts are located next to the internal jugular vein to the neurovascular bundle and can be single chamber or multi-chamber. If serous side cyst increases in size, it is able to squeeze the nervous vascular tissue and nearby organs. Lateral neck cysts are more dangerous than the medial, if only because they are capable of malignant transformation. Points of opening of sinuses originating from the thyroglossal duct and brachial clefts. You can see on this picture. Cervical fistula or sinuses may extend either completely through from the surface of the pharynx or may open internally or externally or be closed at both ends, in which last case the contents accumulate and form a cervical cyst. Fistula arising from the second visceral cleft open externally opposite the thyroid space in front of the sternocleidomastoid muscle. Internally they open into the recess holding the tonsil. Fistula arising from the third and fourth visceral clefts open externally lower down nearer the sternocleidomastoid articulation in front of the sternocleidomastoid muscle and internally in the sinus piriformis. The persistence of the third and fourth visceral clefts internally may produce pharyngeal diverticula, as already noted in discussing that region. In attempting the cure of cysts and fistula due to the persistence of the visceral clefts, it is evident that as they are lined with a secreting epithelium, this must be destroyed or removed, or a recurrence will take place. In attempting to dissect them out, one must be prepared to follow them through the structures of the neck to the pharynx inside. It is needless to say this may be a serious procedure. Median cervical fistula and cyst originate in connection with the thyroglossal duct. This is the embryo leads to the foramen cecum and the roof of the tongue through the posterior surface of the hyoid bone, and thence downward and forward to the isthmus of the thyroid gland. It begins to atrophy in the 5th week and is obliterated by the 8th. According to the Sutton, these cysts are never congenital but occur soon after birth or as late as the 14th year. They appear as rounded cyst tumors just below the hyoid bone or over the thyroid cartilage. On this picture, you can see median cervical porch or cyst arising from the thyroglossal duct. Median cervical cyst. Then let's talk about the tracheotomy. The tracheotomy is a surgical procedure which consists of making an incision on the anterior aspect of the neck and open a direct airway through an incision in the trachea. Trachea, in other words, windpipe. The resulting stoma hole of the tracheostomy can serve independently as an airway or as a site for a tracheostomy tube to be inserted. This tube allows a person to breathe without the use of nose or mouth. There are 4 main reasons why someone would receive a tracheotomy. First one, emergency airway access. Second, airway access for prolonged mechanical ventilation. Third, functional or mechanical upper airway obstruction. And fourth, decreased incompetent clearance of tracheobronchial secretions. In the acute short-term setting, indication for the tracheotomy include such conditions as severe facial or cervical trauma, tumors of the head and neck, cancers, branchial cleft cyst and others, and acute angioedema and inflammation of the head and neck. In the context of failed tracheal intubation, either tracheotomy or cricothyrotomy may be performed. The term tracheostomy is sometimes used interchangeably with tracheotomy. Strictly speaking, however, tracheostomy usually refers to the opening itself, while a tracheotomy is the actual operation. Inferior tracheotomy is that performed below the isthmus of the thyroid, and superior tracheotomy is that performed above the isthmus of the thyroid. A transverse incision through the skin of the neck and anterior wall of the trachea, tracheostomy, establishes an airway in the patients with upper airway obstruction or respiratory failure. The infrahyoid muscles are retracted laterally and the isthmus of the thyroid gland is either divided or retracted superiorly. An opening is made in the trachea between the first and second tracheal rings or through the from the second to the fourth rings, of course. And the tracheostomy tube is then inserted into the trachea and secured. Stages. Let's discuss the tracheotomy and tracheostomy stage by stage. The physician or surgeon will follow these steps in performing this procedure. First, vertical incision is made through the skin. Second, another incision is made through the subcutaneous tissues and muscles of the neck. Third, the neck muscles are separated using retractors. Fourth, the thyroid isthmus is either cut or retracted. Fifth, surgeon identifies the rings or cartilages that make up the trachea and cuts into the walls. And sixth, a metal or plastic tube is inserted into the opening, and sutures are used to hold the tube in its place. Now you can see the schematic representation or formation of round tracheostomic opening by cutting out the fragment of the front wall of the trachea. Completed tracheotomy. A tracheostomy tube consists of an outer cannula and main shaft, an inner cannula and an obturator. The obturator is used when inserting the tracheostomy tube to guide the placement of the outer cannula, and it's removed once the outer cannula is in place. The outer cannula remains the place, but because of the build-up, the secretion, there is an inner cannula that may be removed for cleaning or replaced. Tracheostomy tubes may have cuffs, inflatable balloons, and the end of the tube to secure it in place. A tracheostomy tube may be fenestrated with one or several holes to let air through the larynx, allowing speech. Now, on this picture, you can see the construction of the tracheostomy tube. An outer cannula, top item, with inflatable cuff, top right, an inner cannula, center item, and an obturator, bottom item. Long-term ventilation as the first indication for the tracheostomy. In the chronic long-term settings, indications for tracheostomy include the need for long-term mechanical ventilation and tracheal toilet. Comatose patient or extensive surgery involving the head and neck. Then, bypassing upper airway blockages. In the acute short-term settings, indications for tracheotomy include such conditions as severe facial trauma, tumors of the head and neck, such as cancers, branchial cleft cysts, and so on, and acute angioedemas and inflammation of the head and neck. In the context of failed orotracheal or nasotracheal intubation, either tracheostomy or cricothyrotomy may be performed. Here you can see the endotracheal tube above used in acute settings requires sedation. For long-term settings, a tracheostomy tube is used instead. This picture demonstrates us the cricothyrotomy, an urgent manipulation. Cricothyrotomy, also called coniotomy or emergency airway puncture, is an incision made through the skin and cricothyroid membrane to establish a patient airway during certain life-threatening situations, such as airway obstruction by a foreign body, angioedema, or massive facial trauma. Indications: cricothyrotomy is nearly always performed as a last resort in cases where orotracheal or nasotracheal intubation are impossible or contraindicated. Cricothyrotomy is easier and quicker to perform than tracheotomy and is associated with fewer complications. Contraindications: inability to identify landmarks, cricothyroid membrane first of all. Second contraindication, underlying anatomical abnormalities such as a tumor or severe goiter. Third one, tracheal transection. Fourth, acute laryngeal disease due to infection or trauma. And the fifth, small children under 10 years old. Procedure of cricothyrotomy. In cricothyrotomy, the incision or puncture is made through the cricothyroid membrane in between the thyroid cartilage and the cricoid cartilage. This procedure was first described in 1805 by Félix Vigdazir, a French surgeon and anatomist. A cricothyrotomy is generally performed by making a vertical incision on the skin of the neck just below the laryngeal prominence. This laryngeal prominence is also called Adam's apple. Then making another transverse incision in the cricothyroid membrane, which lies deeper to this point. A tracheostomy tube or endotracheal tube with a 6 or 7 millimeters internal diameter is then inserted. The cuff is inflated and the tube is secured. This picture shows us the procedure of cricothyrotomy. Now you can see the models of tracheotomic cannula, and tracheostomic cannula, of course. Complications. This picture shows us schematic representation of some complications of tracheostomy. A. Incision of a cannula when the mucous membrane is not dissected, as a result of which the cannula falls between the mucous membrane and the cartilage of the trachea. B. The inflatable cuff is torn, its end has fallen down and closed the opening of the cannula. C. Tracheal deformity due to mismatch of the cannula and trachea curvature. F. Incorrect position of the cannula in which it's lower and injures the posterior wall of the trachea. To avoid complications during a tracheostomy, the following anatomical relationships are important. The inferior thyroid veins arise from a venous plexus on the thyroid gland and ascend anterior to the trachea. A small thyroid ema artery is present in approximately 10% of people. It ascends from the brachiocephalic trunk of the arch of the aorta to the isthmus of the thyroid gland. The left brachiocephalic vein, jugular venous arch, and pleura may be encountered particularly in infants and children. The thymus covers the inferior part of the trachea in infants and children. The trachea is small, mobile, and soft in infants, making it easy to cut through its posterior wall and damage the esophagus. Those moments are very important. They have their clinical and anatomical base. That's why all doctors should remember it. My dear friends, thank you very much for your respectful attention. The lecture is over. See you later. Wish you good luck. Goodbye.